Hello everyone, my name is Dr. Ambit Misra, and in today's discussion we are going to discuss about the basic pathophysiology that is involved behind the diseases that are going to involve your nephrons, and some really basic ultrastructure of nephrons that and the different parts of the nephrons that are going to get involved in these diseases. So starting with the the ultrastructure of these nephrons. So what all components that we need to keep in mind, their function, their structure, and how in turn they are going to get affected in the diseases. So these are your glomerulus and your vasa recta, your Bowman's capsule, mesangium, tubules, and your tubular interstitium. So we will discuss all these one by one, their structure, their function, and how they are going to look, and how the pathologies are going to involve these structures. So we always had hard time understanding the pathophysiology and the diseases of nephrons, and this video is particularly about how to approach those diseases. So starting with the glomerulus, we are all familiar with the structure that these are the tuft of capillaries that are just folded and turned and wind around, and it is present inside the Bowman's capsule. This is the rough idea that we already have, but we will see the full story. So the glomerulus, this is going to start from your arcuate artery. See, your renal artery, which is in turn is going to give a lobar branch, and from lobar branch, this arcuate artery originates. Now, this arcuate artery is going to give a branch that is your interlobular artery, and this interlobular artery is going to in turn form your afferent arteriole. So, your afferent arteriole, it comes from your interlobular arteries, which get turned around, and it has multiple folds, and forming a tuft of capillaries, that is your glomerulus. And this whole structure, whole bunch of capillary is going to embedded inside the mesangial matrix. So let's suppose this is your tuft of capillaries and this is your mesangium, so it's like surrounded by this mesangial matrix. So this glomerulus is in turn is surrounded by mesangial matrix. Now now this mesangial matrix is not present in every part of your Bowman space, which in turn we will see from a picture, and we will have a better idea. Now this glomeruli is going to continue forming efferent arteriole, and this efferent arteriole is going to form vasa recta and peritubular capillaries. See, vasa recta and peritubular capillaries, these the vasa recta is the continuation of peritubular capillaries. So this if efferent arteriole is going to form peritubular capillaries, these capillaries are woven around the tubules, which again is going to continue into vasa recta. So vasa recta is mainly involved in the exchange, but peritubular capillaries are not. So vasa recta peritubular capillaries are going to continue forming vasa recta, and further this is going to drain into interlobular vein, and further into arcuate vein, and then into renal vein. So this is the whole architecture of how a glomerulus is going to formed. Now see, this is the structure. This by this, like, you can have a better understanding. This over here is your interlobular artery, and this is your interlobular vein. This interlobular artery is going to form afferent arteriole, and this afferent arteriole is going to in turn after forming glomerulus, it is going to exit the Bowman's capsule, forming efferent arteriole, And these all, see, these are your peritubular capillaries that are, surrounding the tubules. And this over here, see, these are your vasa recta that are going to get involved in the exchange. Now, this is the basic structure of nephron that you must be already familiar. This is your glomerulus over here. This is your glomerulus. So this is the basic structure of a nephron. Now, this glomeruli, okay, this sits on glomerular basement membrane bed, and this glomerular basement membrane along with glomerulus, it is surrounded by podocytes. This is surrounded by your podocytes. See, these three structures, these are attached to one another. So first your endothelium of your glomerulus, then comes your basement membrane, and the podocyte is surrounding these two all together. So it's like covering these two structures, and in turn all these three is going to form your filtration barrier. So what is filtration barrier? See, glomerulus along with GBM and podocyte. So these three structures, glomerulus, GBM and podocyte, these are going to form your filtration barrier. So the three structures that are involved is your glomerular endothelium, that is fenestrated. It is fenestrated. It has multiple pores, in order to pass the plasma from glomerulus into the Bowman space. So these are fenestrated. Through these fenestrations, these filtrate is going to pass on to the Bowman space and again into the tubules. Now it has glycocalyx, which contains negative charge. So glomerular endothelium is first, it is fenestrated, it has pores, and it contains glycocalyx that contains negative charge. And what is the importance of this negative charge? We will see further. Second is your glomerular basement membrane, which have pores. This also have pores, and it contains heparan sulfate, and it also have negative charge. Then comes your podocytes, and podocytes contain food processes. These food processes are interconnected. See, like this. So when these are interconnected, these have these spaces. So these spaces, these are going to form slit pores. So these food processes of podocytes are interconnected, and these in turn are going to form your slit pore. So we saw that all these three structures, your endothelium, your basement membrane, and your podocyte, the food processes of podocytes, all these contain some space for the filtrate to pass through. So ultimately these are together combined going to form filtration barrier, because this barrier which is going to oppose transfer of proteins and other bigger molecules to pass into Bowman's capsule and then come into tubules and then into urine. So this is the barrier, main barrier, which is formed by these three structures. Now radius of the filtration barrier, the radius of your filtration barrier, these three structures combined, if we have to say what is the maximum size of a molecule that can pass through this barrier, so we will see so we can say what is the radius of filtration barrier. That means what is the biggest molecule that can pass through this filtration barrier. That is your 4 nanometers. And what is the radius of albumin? It is 3.6 nanometers. So this, I'm talking about radius, not diameter. So we are talking about radius. So 4 nanometer is the radius of your filtration barrier. Beyond 4 nanometer, the molecules which are greater than 4 nanometer in the radius, in the size, cannot pass through this barrier. Now again, we see the factors that are going to oppose filtration of plasma proteins. See, plasma contains so many kinds of proteins, and what are the factors that are going to oppose from passing these proteins into the filtrate and then into the urine? So this is your negative charge of basement membrane and your endothelium, and the pore size of your filtration barrier. These two are the opposing forces, because see, proteins are mainly negatively charged. So the negative charge of basement membrane and endothelium is going to repel these molecules, these proteins which contain negative charge. And also the size of the pore size of filtration barrier is also an opposing force for some most of the plasma proteins. Now for albumin, the glomerulus is said to be an imperfect barrier. Why? Because in normal conditions also albumins are seen in the urine. So that is like 8 to 10 milligrams of albumin in 24 hours. If you collect a urine sample over 24 hours, then 8 to 10 milligrams of albumin is normal. So how, instead of all these barrier, all these factors, this albumin can come into the urine. So instead of negative charge of albumin, it can pass to some extent. And it's like even though the negative charge is going to repel the albumin, the slit pore is a bit larger as compared to the size of albumin. But instead of this repelling force and the size factor, if you combine this all together, the albumin can pass through this to certain extent. That is your 8 to 10 milligrams per 24 hour. So this is the normal amount of albumin that you can see in the 24-hour voided urine sample. Now this is why, like, you can see albumin even in normal physiological conditions. Now through these pictures, like, we can really appreciate how the podocytes actually look like. So like, if you have these pictures embedded inside your mind and you actually know the ultrastructure, how these structures are going to look, it will be a lot easier for you to interpret the functions that they are going to carry further. So it's really important to understand how these structures are going to are attached to each other, how they are placed and how they are arranged and how they look. So that's how you can have a better understanding in certain, not certain, all of the pathologies. So this is your glomerulus here, afferent and efferent arteriole, you can see. That is how the glomerulus is going to form the tuft. This is called tuft because the blood vessels are folded and in circular manner, and this is going to form a bunch, looks like a bunch, which sits in this Bowman's capsule. This is your Bowman's capsule, and these are the podocytes. See this over here, this is your podocyte. This is your podocyte cell body, and these are your food processes. This is your cell body and these are your food processes. So from cell body originates multiple food processes, and again these food processes have pedicles. So podocyte cell body, from that emerges your food processes, and these food processes have pedicles like these fingers. So, and these pedicles are intertangled, arranged like this. That's how they are going to cover, you see, they are going to cover this whole circumference of your endothelium. Now you can also see this endothelium is fenestrated. You can see multiple dots here. So that's how this arrangement of endothelium, basement membrane, and podocytes are going to prevent passage of plasma proteins, and in order to and in turn going to form your filtration barrier. Again, in another picture here, you can see this is your cell body. This they have multiple processes that you can appreciate. This is your pedicle. This over here, these are your pedicles. This is the cell body, this is the pedicle, and here you can see this is the filtration slit. The gap that will be present in between those pedicles, these are going to form filtration slit. Now you can pause and look at this diagram in order to appreciate the structure of podocytes, because most of the time we are confused how these podocytes are going to look, because in when we will study the diseases, these podocytes, when they come into the picture, it's really hard to imagine like how they are going to get defected, and what structure they are going to attain when they are damaged. So just in order to have a better imagination, you can look at this picture. Now see, this we discussed about the glomerulus, your basement membrane, and your podocytes. Now all these three are going to be present inside a space. So this space is known as Bowman's space. All these structures are going to present inside the Bowman space, and this Bowman space is surrounded by Bowman's capsule. Now you see here, this is your Bowman space, and this, sorry, not this one, this is your capillary. You can see here, this is your Bowman space. This is your Bowman space, and this is your Bowman's capsule. All these structure, all this is your collectively your glomerulus, your basement membrane, your podocytes, your mesangium. These collectively these structures are going to look like this on histopathological image. This is your Bowman space. Here is your Bowman's capsule. You can see mesangial cells. These mesangial cells are when the afferent arteriole going to enter inside the Bowman's space, Bowman's capsule. On that verge there are these cells, these mesangial cells. These are nothing but your supporting cells of or you can say this is the extracellular matrix that are these mesangial cells are going to form for these glomerulus. So these mesangial cells are present around around the tuft, outside but around the tuft, and this are going to get it's specialized, and in turn are going to form macula densa. So this is the location of mesangial cells. You can appreciate Bowman's space and Bowman's capsule. Now this Bowman's capsule is going to get formed by parietal epithelial cells. See, there are whenever we are going to discuss about epithelial cells, one is parietal, that is present, that is going to form the Bowman's capsule, and the visceral epithelium is your podocyte. So this parietal epithelial is going to form Bowman's capsule, and this in turn is going to get transitioned and going to form tubular epithelium of the proximal tubules, is going to transition into forming tubular epithelium of proximal tubules. Now see, where is visceral epithelium of Bowman's capsule? It is your podocytes. Podocytes are said to be the visceral epithelium, and the parietal epithelium is going to form the Bowman's capsule. Now in this diagram, in this picture, you can appreciate this is the food process, the filtration slit, that is the gap between these food processes. This is the capillary lumen here, and you see, you can appreciate the basement membrane between endothelium and podocyte, and you can see, if you can appreciate these fenestrations that are present in the endothelium. So we saw gap here, we saw gap here, and basement membrane is also have pores. So this in turn is going to form, you know your filtration barrier. This is your podocyte, the cell body of a podocyte. These are the food processes, and this is the podocyte, and this is the normal histopathological picture of a glomerulus, of Bowman's capsule, Bowman's space. Everything you can appreciate in this normal pathological image. Now moving on to next, you can also appreciate some other pictures here. You see, this is your mesangium. You can see all these structures here, all these are going to form mesangium. So these mesangium are present in between all those, in between the tufts of the capillaries. Now here you can appreciate your podocytes, and this is the basement membrane. Here in this picture, uh, can you compare this picture from this picture? You see, this Bowman space is uniform throughout. Like you can see, wide Bowman space, but here the Bowman space is like, you cannot appreciate some part of Bowman space. Here, all this the glomerulus and the surrounding structures are looking uniform, but here can you appreciate this area? This is the sclerosis of Bowman's capsule. This is how the sclerosis is going to appear, in histopathological picture. So this is the picture of FSGS. This is how focal segmental glomerulosclerosis is going to look. See, this part of glomerulus is completely sclerosed, and you can see deposition of this pink material, and this part is normal. So the glomerulus is focally, sclerosed. That is your FSGS. So this is kind of image or histopathological image you are going to see in case of FSGS. Just in order to appreciate the difference between the normal image and the image of FSGS. Moving on to tubulointerstitium. So tubulointerstitium is nothing but your tubules and the interstitium combined. And what is your interstitium? So interstitium is nothing but all these structures excluding tubules which are present around the tubules is your interstitium. So if you can think of some tubules, and surrounding these tubules some structures are present, that is your interstitium. So this is the structure surrounding the tubules, that is your interstitium, and it includes extracellular matrix, and some cells like macrophages, fibroblast, and the fluids that are going to get exchanged between your vasa recta and your loop of Henle's. So this is the interstitium. You have a rough idea about how these structures are going to form, and how these structures, like you should know how to locate these structures like in your mind, so that when you are studying any pathology, any disease, now so then you can think about how these structures are, how if there is fibrosis, or there is sclerosis, or there is inflammation, or there is deposition of immune complexes, where actually these things are going to happen, which structure is going to involve. So in order to you get that, you must have a rough idea about these structures. Now, pathogenesis of glomerular diseases. See, uh, you have a normal glomerulus. There are multiple ways by which these structures, maybe single or multiple, can get affected, which will in turn lead to certain pathology, certain diseases, certain syndromes. So there are multiple ways by which these structures can get affected. So that is, it could be due to genetic mutation, it could be due to some toxin, any infection, any autoimmunity, hypertension, buildup of thrombus, atherosclerosis of the arterioles, the all these all the vascularity, and diabetes mellitus, and some other factors. Now we will see some of them, starting with the genetic mutations. So mutation in NPHS1 gene, that codes for nephrin, and NPHS2, which codes for podosine. So when these are affected, and these are the patient is generally affected from the birth. So this, when these genes are affected, they are going to affect your slit pore, the pores that were formed from the podocytes, the food process of podocytes. So these pores are going to get affected, and which in turn is going to lead to congenital nephrotic syndrome. This is going to lead to congenital nephrotic syndrome when the defect is in NPHS1 and NPHS2 gene, which codes for nephrin and podosine respectively. This is going to affect your slit pores of your podocytes, and these are going to be affected from the birth, and which in turn going to lead to congenital nephrotic syndrome. Now again, mutation in gene encoding these subunits of type 4 collagen, alpha 3, alpha 4, and alpha 5 units of type 4 collagen, then this is going to lead to your Alport syndrome. Alport syndrome. So Alport syndrome, you are going to see when there is mutation in the gene encoding alpha 3, alpha 4, and alpha 5 subunits of type 4 collagen. Now, how systemic hypertension and atherosclerosis is going to affect the glomerular function? That is, this is going to induce pressure stress, and when the there is atherosclerosis, the blood flow is going to get reduced. That is going to lead to ischemia. So this in turn is going to cause your chronic glomerulosclerosis. Chronic glomerulosclerosis. See how it is going to lead to sclerosis. So whenever the blood flow is going to get decreased to certain part of your glomerulus, or certain, or in that extent, or in that in any part, if there is blood, if the blood flow is going to get reduced, the cells are going to die. And when the cells are going to die, there will be apoptosis. And when there will be apoptosis, this all orchestra of all this is going to stimulate fibroblast, and these fibroblasts are going to these are responsible for the sclerosis. So this is how in bigger terms, in lame terms, you can say, is going to cause chronic glomerulosclerosis. Next one is your inflammation of your glomerular capillaries. So what is going to happen when there will be inflammation of your glomerular capillaries? This is going to cause glomerular, or you can say glomerulonephritis. Now, you see, there are multiple ways by which these structures can be affected. You see, in case of autoimmunity, also the immune complexes, which either could be from the endogenous antigens, exogenous antigens, or the preformed circulating antibodies, circulating immune complexes. They can come and deposited, in various places, and when they are going to get deposited, they are going to elicit some kind of response, because they cannot always stay there. They must be, eliminated. So there must be incorporation of macrophages, neutrophils, T lymphocytes, in order to eliminate those immune complexes. And when they come, they, elicit an inflammatory response. And in order to eliminate these unwanted, molecules, the inflammation is going to occur, and this inflammation is going to damage those normal structures which are functioning normally, and which in turn is going to affect the functioning of nephron as a whole. Now, see, immune complexes deposition due to, it could be due to toxin, infection, autoimmunity. See, in case of an infection, the antigen of that particular infection can be present somewhere else in the body, and can come and deposit inside the nephrons. Or there could be preformed antibodies, autoantibodies, uh, that are going to attack, in case of autoimmunity, the preformed antibodies are going to attack these normal structures. And if there are some kind of toxins, in order to eliminate, because you see, ultimately your blood is going to pass through the kidneys. So whatever is present inside the blood, your toxins, your antibodies, your antigens, your infections, your bacteria, your immune complexes, they are ultimately going to come through this glomerulus, and they must pass through the barrier of glomerulus in order to exit through the body. But if they are present and they have tendency to deposit to any of the places, they can get deposited there, and that's how they can elicit an inflammatory response, which is in turn is going to damage the normal structures. So immune complexes deposited along basement membrane. This could be, you know, in situ immune complexes, or it could be circulating immune complexes. Means the immune complexes that are formed at the particular, at the original site, or it could be the immune complexes which are circulating inside the body, and when ultimately they come through the kidneys and they come to the glomerulus, and they can get deposited there. So this this is going to draw macrophages, neutrophils, and T lymphocytes. So whenever these complexes are going to, get collected along the basement membrane, because basement membrane is the barrier which is going to stop all these. So they are ultimately get encountered by basement membrane, and if they cannot pass through, they are going to get deposited there in the subendothelial space, or you can say between the endothelium and basement membrane. So between endothelium and basement membrane, when these complexes are deposited, they elicit immune response. So macrophages will come, neutrophils and T lymphocytes will come in order to, eliminate these immune complexes, and which will elicit inflammatory response. And that's how your glomerulus is going to get inflamed. And whenever there is inflammation, cells are going to die. There will be apoptosis, there will be sclerosis, there will be fibrosis, there will be incorporation of fibroblast. So there will be ultimately the glomerulus is going to get sclerosed, fibrosed, and they are going to lose cellularity. They are going to lose their function. So that's how the immune complexes through various ways can deposit. and elicit these inflammatory responses. So from this picture you can understand this is your exogenous antigen, this is your exogenous antigen, endogenous antigen, and these are your preformed immune complexes. It could be either endogenous or exogenous. It could be either it could have been formed inside at the original site, or it could have come from from the circulation through some other part of your body. So these are going to elicit an immune response, and which will in turn cause induce inflammatory response, and in turn cause sclerosis. So this is how like whenever you see the term sclerosis or fibrosis, so this is the pathophysiology behind it, how the situation came uh, to fibrosis of particular structure, how this structure got fibrosed. So this is how it all starts. See, in all these cases, whenever there is in case of genetic mutations, you can see like there is it is going to affect slit pores. Here in Alport syndrome there will be loss of uh, collagen. In case of hypertension atherosclerosis, there is going to be glomerular sclerosis. Why? Because there will be ischemia. Ischemia is ultimately going to lead to sclerosis. Inflammation is also ultimately going to damage the normal structures and going to cause inflammation, that is your nephritis, and these immune complexes that we saw. So this is the picture. This is how uh, you know uh, a normal structure, the normal nephrons, normal glomerulus and your tubules are going to land up into stage of fibrosis. So whenever you hear the term fibrosis, this is all the pathogenesis step by step that led to formation of fibrosis inside these particular structures. Now immunofluorescence is a way that you can view the deposition of these immune complexes. So this is your linear and this is your granular immunofluorescence. In linear, you see only the linear pattern of deposition of immune complexes. In granular, you are going to see granules. The it will not be visible as something uniform, and it will be like dots and dots. So that is your glomerular. So where you are going to see linear, it is your Goodpasture syndrome. There will be deposition of IgG. Please keep in mind, it is only antibody that is going to get deposited in case of Goodpasture syndrome, not the immune complexes. So whenever you see linear immunofluorescence, it is your antibodies that are going to get deposited, not immune complexes. When the immune complexes are going to get deposited in case of membranous nephropathy, that is also IgG. So whenever this immune complex is going to get deposited, it is going to cause granular presentation of your glomeruli. And in Goodpasture, it is your linear because it's not immune complex, it is your antibody only. Now see, whenever there is persistent damage to your glomerular capillaries, and how this damage to the capillaries, damage to the glomerulus is going to spread the same pathology to your tubules. See, because the affected part was your glomerulus, it was inflamed. Your tubules are normal, your tubulointerstitium is normal, but how this inflammation of glomerulus is going to affect your tubules and your interstitium. So whenever the glomerulus is affected, inflamed, and all these things, there will be proteinuria. See, so there is increased protein into the filtrate, and this filtrate is going to pass through these tubules. So this filtrate, they carry activated cytokines and lipoproteins, and these lipoproteins, they carry reactive oxygen species. Now, whenever they reach the tubules, they initiate inflammatory cascade inside the tubular epithelium and around the tubular epithelium. Now, this inflammatory cascade is going to incorporate T lymphocytes and macrophages, you know, in the interstitial space. And whenever there is inflammation, there is going to be fibrosis. Ultimately, this will land up into fibrosis, because in order to subside the inflammation, or this is how the body manages with the inflammation inside, in the visceral organs. So whenever there is inflammatory cascade, there will be incorporation of T lymphocytes and macrophages, just because to clear whatever abnormality that has come to that place. So the main responsibility of these is to clear that. But what happens when they clear it? There is activation of your fibroblast, and they are going to cause fibrosis and tubular atrophy. See, whenever there is inflammation, there is going to be atrophy. The tubules are going to lose their function. They are going to get reduced in size. Their function is going to get reduced, and also there will be fibrosis. And this fibrosis, this will incorporate TGF beta, platelet derived growth factor, and fibroblast growth factor 2. These become active. Fibroblast multiply, and there is formation of scar tissue. And to resolve this scar tissue, apoptosis occurs, and that's how your renal failure occurs. So this is the cascade. This is the stepwise cascade how proteinuria can cause renal failure. There is protein is going to they are going to carry some, because protein is not normal, like protein being inside the filtrate, which has been already filtered, which has come from the glomerulus into the tubules. If there are proteins, it's not normal. So whenever there is something not normal, the body is going to elicit some kind of response. So whenever these proteins land up into the tubules, which shouldn't be there, this is going to activate cytokines, and there also be lipoproteins, because it is a stage of hyperlipidemia, hypercholesterolemia, which will initiate inflammatory cascade, incorporation of your lymphocytes, macrophages, neutrophils, and all those cells, which is going to cause fibrosis and tubular atrophy, which activates your so now whenever the tubules are get atrophied, see these TGF beta, PDGF, these are for these are only for growth. When the tubules are atrophied, they want some kind of growth so that they can make the tubules normal again. But in turn, it land up into activating fibroblast, which is going to form the scar tissue. And now there are no viable nephrons, no working tubules, and that is how this is over the long term is going to cause renal failure. Now this in this picture you can appreciate, this is your crescent formation, that is you are going to see in case of rapidly progressive glomerulonephritis. This is the really differentiating feature of RPGN, where you are going to see this crescent. I hope you can appreciate this. This is your crescent. So what is crescent? Crescent, it's nothing but whenever there is damage to your basement membrane, your podocytes, there will be formation of some pockets, and in those pockets there will be some inflammatory cells. There will be some other filtrate, and there will be going some ongoing inflammatory process inside that pocket, and it grows and grows, and it forms a crescent shape. That is your crescent that you are going to see in case of RPGN. So like you can easily differentiate this from a normal histopathological picture. Now, there whenever the nephrons are affected, any part of nephron is affected, they are going to present with some features, some symptoms, some there will be some clinical picture. So the main three main that we are going to discuss now is your proteinuria, hematuria, and your pyuria. So proteinuria, normal proteinuria, when it is said to be normal, when the amount of protein inside the urine, when you collect the 24-hour urine sample, and when this amount of protein in that sample is less than 150 milligram, is said to be normal. Minimal is your less than 500. Benign when it is less than 1 gram in 24 hours. And benign proteinuria is that you are going to see in case of fever, exercise, obesity, sleep apnea, emotional stress, and congestive heart failure. And sustained proteinuria, that is sustained proteinuria, that is when more than 1 to 2 grams of protein in 24 hours. This you are going to see in case of glomerular diseases. So you must have heard from your friends or someone else or family members that whenever they are going to pee, they see that their urine is foaming. There is formation of foam whenever they are urinating. So foaming, so proteinuria is responsible for foaming of the urine. So whenever in certain conditions like you have fever or during exercise, in case of obesity, sleep apnea, like if the person is going through any of these situations, they can see foaming of urine, that will be because of proteins that are present inside the urine. Now you see, patients are usually unaware. So whenever these structures are getting affected and there is proteinuria to some extent, some lesser extent, patient cannot appreciate, cannot see that there is proteinuria until or unless the patient is going to land up into some symptoms, like whenever the patient see the foaming of urine, or whenever the patient is edematous, there is some other symptoms, then they are going to appreciate that okay, like there must be some kind of abnormality going on. Otherwise, minimal proteinuria is really hard to judge by the patient itself. Otherwise, when the proteinuria is like benign and more than that, patient can appreciate. And until that, if in talking about glomerular diseases, let's just say that there is a patient with ongoing glomerular damage, and proteinuria start to appear, like protein start to appear inside the urine. There is not that significant proteinuria, but there is proteinuria. But patient cannot know because there are no symptoms. Only there is protein inside the urine, but that indicates early damage to the nephrons, to the glomerulus. And there is no way that if there are no symptoms and there is no difficulty in the lifestyle, in the life of the patient cannot know that the ongoing proteinuria is there and there is ongoing damage to the glomerulus. The patient only notices when there are symptoms, that is your foaming, your edema and all. So see, selective proteinuria. What is selective proteinuria? Selective proteinuria means only albumin is present. Selective proteinuria means if there is only albumin that is present inside the urine, that is going to that will be the cause of proteinuria, that is only albumin. So that you are going to see in case of minimal change disease. Minimal change disease is only seen in children. So in case of minimal change disease, which is seen in case of children, you are going to see selective proteinuria. You are not going to see other proteins, you are only going to see albumin inside the urine. That is your selective proteinuria, and which is seen in case of minimal change disease. Non-selective proteinuria means albumin plus other serum proteins, and this you are going to see in case of FSGS and di- and diabetic nephropathy, and also glomerulonephritis. So in these cases, you are going to see non-selective proteinuria, that is protein is present along with other plasma proteins. Now albuminuria. See, albuminuria and proteinuria. Albumin is a kind of protein. Albumin is a protein, right? So why we say albuminuria and proteinuria differently? Because there could be only albumin inside the urine and no protein, and there could be albumin along with some other plasma proteins. So that's why we usually say it separately. We cannot combine these two. So normal albuminuria is your 8 to 10 milligram per 24 hours. Microalbuminuria, when the albumin is your 30 to 300 milligrams in 24 hours, and in dipstick it is said to be 1 plus. So whenever you say there is albuminuria plus 1 plus, that is your microalbuminuria, and beyond that you are going to say it proteinuria. And because you see, uh, why we are going to say proteinuria, or like why it's significant, because when you are going to measure proteins that is present in any pathology inside in the urine, it is mostly albumin. Only a small fraction of other proteins that will be present along with albumin. So albumin forms the major portion of all these proteins. So that's why we will consider here proteinuria when there is excess of albumin inside the urine. That will be your 3 plus in dipstick. Now hematuria, see, whenever whenever your glomerulus is going to get injured due to various reasons, that is your inflammation, could be immune mediated, that we saw genetic defects and all that. This causes blood to leak out from the glomerulus, causing blood cells to leak out, causing hematuria and some degree of proteinuria. So this is only because your glomerulus is damaged. See, hematuria can be the origin of hematuria could be many. It but we need to specify here. We need to consider here the blood that is coming from your glomerulus, your nephrons, and not from the other pathologies. So whenever the glomerulus is affected, inflamed or damaged, and the blood comes into the urine, that is your hematuria that we are going to discuss further in certain pathologies related to your nephrons. Now microscopic hematuria, when your 3 to 5 RBCs are present in the sediment from the first voided urine, from the morning sample of urine, and when only 3 to 5 RBCs are present inside the urine, patient cannot see this from the naked eye. In order to appreciate hematuria, blood in the urine, patient need to see it, in order to appreciate it, that there is change in color of the urine. But microscopic hematuria, patient cannot see from the visible eyes, but there is ongoing damage to the glomerulus, and patient is actually unaware about it. And if there is proteinuria along with this hematuria, that proteinuria will also not be so significant, so that patient can appreciate it. And if there are no symptoms, and there are microscopic hematuria and minimal proteinuria, the patient is unaware about this, but there is ongoing damage to the glomerulus. So that's how it is really important to uh, get this idea of how to uh, how to diagnose a patient in early stages, whenever there is no like visible symptoms, patient is unaware but there is ongoing damage. So this is the reason, the most in most of the cases the diagnosis is delayed, and patient presents very late when there are significant amount of symptoms, and patient is really uncomfortable. Until the patient is normal, patient doesn't comes, but there is ongoing damage to the structures of nephrons. Now gross hematuria, we will see the gross hematuria when the blood that is in the urine is visible to the naked eye. Like patient can see if there is the change in color of the urine because of the blood. So that is your gross hematuria. And gross hematuria that you are going to see in case of gross hematuria, you are going to see in case of this is your sickle cell anemia and your IgA nephropathy. In these two situations, sickle cell anemia and IgA nephropathy, you are going to see gross hematuria. The color of the urine is red, and the patient is able to appreciate that it is hematuria. The blood is present inside the urine. Now, hematuria, the origin of the blood that is present in the urine could be your glomerulus, your nephrons, and it could be something else also. So we really need to differentiate. If we see hematuria, see when the patient comes and it complains of hematuria, or the patient doesn't complain, you just saw in the report that there is hematuria, there are blood cells that is present in the urine. Your first responsibility is to differentiate if this blood is from the nephrons or from the other structures. So hematuria, which is not glomerular, and it is the origin of it is somewhere else, that is seen in case of malignancy of uh, any part of urinary tract. It could be benign prostatic hyperplasia. It could be papillary necrosis. It could be renal stones. It could be hypercalciuria or cystic kidney disease. So in these conditions, in these certain conditions, the blood, the hematuria, is not glomerular in origin. Now hematuria is also seen in case of interstitial nephritis. All these pathologies, all these diseases we are going to see in the next video. We are just having a rough idea about the pathologies, about these structures, about the mechanisms behind all these pathologies. So we will just have a rough idea about all these diseases and all the pathologies, and how the disease progresses from like from normal to being abnormal, in the abnormal, like causing like affecting the structures from normal to abnormal. So we are just going to see that in the video. In the next video we are going to see the diseases particular, and we will discuss properly. Here we are just having a rough idea about it. Now RBC cast or dysmorphic RBCs that we are going to see in case of your glomerulonephritis. What is RBC cast? That we will see in the next video. RBC cast is basically whenever the RBCs are present over a cast, and this cast is nothing but your tubular, like this cast is present inside the your tubules, and it mainly formed from the tubular epithelium. So the RBC sits on this cast, so it is your RBC cast. And we are going to see this in case of glomerulonephritis, and we will see uh, in detail in the next video. So it is said that always view hematuria along with the clinical picture. Why? Because if you are seeing hematuria but there is no clinical picture of nephrotic or nephritic or any pathology involving nephrons, you can formulate you know and go for examining other pathologies that is that is not involving glomerulus. So all these could be in your you know uh, could be the diagnosis. Now pyuria, it is seen in case of inflammation. Whenever there is inflammation, there will be pyuria, and it is seen in case of your PSGN, that is your post streptococcal glomerulonephritis, and your MPGN, that is your membranoproliferative glomerulonephritis. What is the significant number of leukocyte in urine so that you can say it is pyuria? That is more than or equal to 10 WBCs per millimeter cube, or you can say more than 3 WBCs per high power field. Now this should be this should be differentiated from the urine that is infected with bacteria. These two are different things. So if the urine is infected with bacteria, the pathology could be lying in the bladder, or could be in the in other parts of urinary tract, not the glomerulus or nephron. Now what are the parameters that we need to assess the glomerular function or glomerular injury? That is there will be decrease in GFR, glomerular filtration rate. There will be proteinuria. There will be hematuria with or without the cast. There will be pyuria. There will be fluid retention, that is edema, or you can say anasarca, and there will be increased serum creatinine. So whenever a patient you know uh, comes with any such symptoms, single or multiple, you should have a rough idea about, you in the back of the mind you have idea about all these glomerular diseases. It could be any of these, and that's how we should start our investigation further. So like these are the presenting symptoms, see, presenting features of the glomerular injury. If there is glomerular inflammation that is going to develop slowly, so see, whenever there is damage to the glomerulus, or there is inflammation in the glomerulus, uh, you are going to see increased level of serum creatinine, because serum creatinine is one of the markers that is going to get raised whenever the there is some kind of injury to the glomerulus, because this creatinine is filtered normally, like it is present inside the urine, like you will see normally. It is also there are some at some to some extent it is present inside the circulation, but when the glomerulus is damaged, the filtration is going to get affected, and this will cause increase in a level of serum creatinine, because the blood is not getting filtered properly. That means the creatinine is also not getting filtered properly, which is in turn going to be raised inside the circulation. So when the injury is gradual, like over the weeks to months, so this serum creatinine is going to rise very slowly. That you are going to see in case of chronic kidney disease and glomerulonephritis. But whenever this serum creatinine increases quickly, that means the ongoing injury is also happening quickly. The damage is fast. That you are going to see in case of acute nephritis or RPGN. In RPGN you are going to see crescent, that we have discussed. So whenever this RPGN is going to present with lung hemorrhage, when there is features of RPGN along with lung hemorrhage, you are going to think about certain syndromes, which are your Goodpasture syndrome ANCA, small vessel vasculitis, that includes your GPA, MP, and Churg-Strauss, and your henoch-Solin purpura, and your lupus erythematosus. So these are conditions that are going to cause lung hemorrhage along with RPGN like picture, and which is known as pulmonary renal syndrome. So in pulmonary renal syndrome, we are going to see these pathologies, these syndromes, that is your good pasture, ANCA, small vessel vasculitis, henoch-Solin purpura, and your lupus erythematosus. You need to remember this. Now, what is the mechanism of proteinuria? Why the proteinuria is going to, like, what is the actual, you know, what is the actual damage that is going to cause protein to leak out from the, you know, glomerulus into the urine, into the filtrate? See, first, whenever the glomerulus is damaged, there will be loss of negative charge. This negative charge is present in endothelium and basement membrane, and whenever there is the damage of these structures, there will be loss of negative charge, and also there will be structural damage to the podocytes, or you can say slit diaphragm or the slit pores. So this is going to cause loss of selectivity. You see the filtration slit. This is also a selective barrier. This is going to select what molecules that should be passed through this. This is also selective in nature. So there will be loss of selectivity. There will be loss of negative charge. This allows loss of protein that was previously restricted, you know, to pass through this filtration slit because of the damage and due to any kind of inflammation, or you know, any physical damage to any of these structure due to any reason is going to cause loss of negative charge and, you know, structural damage to podocytes, which will going to cause, you know, proteins to leak out from these structures. Now uh, you must think like, whenever there is ongoing damage to the glomerulus and nephrons as a whole, because whenever there is damage to glomerulus, this damage is going to transmit to is going to pass to your tubules. Your tubules are going to get damaged ultimately because your glomerulus is damaged. Until or unless preventive measures are taken, the damage to glomerulus is going to get transmitted to tubules ultimately. So why proteins are getting leaked out from the glomerulus, but there is decrease in GFR? You must, you know, think, if there is increase in pore size, there must be more water that is, you know, passing from the glomerulus into the, you know, tubules and then into the urine. So GFR must be increased, but this is not how it happens. There is proteinuria, but along with that there is decrease in GFR. So how proteinuria, there is increase in pore size and that causes proteinuria but decrease in GFR? This we are going to see. So what is the mechanism behind decrease in GFR? You know, uh, although because of increase in pore size there is increased permeability, which is going to increase, you must think that this is going to increase the filtration and filtration rate, and there will be more filtrate. But you see, this is not how it happens. So along with that there is structural damage and scarring. That means if there were, let's just say, 100 nephrons in normal kidneys, in like, just for, you know, sake of understanding, let's just say there are 100 nephrons, all are functioning properly, there is no damage, then there are some kind of inflammation is going on, and out of those 100, 20 nephrons are now damaged. Now out of these 20 nephrons, the pore size is increased, but there is ongoing inflammation, damage and scarring to, you know, these 20 nephrons, these 20 glomeruli. And if you imagine glomerulus as a single structure, there is increase in pore size, but there is scarring also. So ultimately, like if you combine all this, there will be, the glomerulus is going to get hardened, and this is going to decrease the surface area. There are more, the size of pore is more, that's obvious. But due to scarring, the glomerulus is hard now, and there is less surface area available for filtration. So this is going to contribute to decrease in GFR. Next is your capillary narrowing collapse. You see, because of scarring, whenever the scarring occurs, this scarring is going to, narrow the capillaries, and this narrowing is going to decrease the blood flow, and this is again going to decrease the filtration pressure and filtration volume. Again, this glomerular injury is going to, transmit it to your tubulointerstitial injury. And this excessive protein that we saw, that how the excessive protein is going to cause inflammation in your tubules. This is toxic to tubular cells, and it causes inflammation, fibrosis in the interstitium. And that's how, whenever the interstitium is fibrosed, there is, the size of nephrons decreases. There is tubular atrophy. There is, scarring, and the number of functional nephrons also decreases. So that also is going to contribute to decrease in the GFR and decrease in filtration. Then next is your hemodynamic change. How this occurs? See, whenever the GFR decreases due to all these reasons, the body tries to compensate, and it tries to maintain the GFR. So let's just say there were 100 nephrons that were normal, now 20 are affected. So body will, try to make those remaining 80 normal nephrons to work more. And whenever, the body imposes more workload to the normal healthy nephrons, they also start to get damaged. And they initially is going to maintain the GFR, but eventually they cause more damage to the healthy nephrons and accelerate the nephron loss. So now, out of those 80 healthy nephrons, the number of healthy nephrons will keep on decreasing, and there will be more nephron loss, which will also going to contribute to decrease in GFR. So that's how, if you are thinking there is increase in pore size, then there should be increase in GFR, but GFR is decreased. So these are the factors that are going to decrease the GFR, and at the same time causing proteinuria. So this statement, it says that increase in pore size is significantly related to defect in selectively causing protein loss. That means protein loss or proteinuria is, the main factor is your increase in pore size, but decrease in GFR is the consequence of progressive and permanent structural dysfunction. See, whenever you see proteinuria, just in the back of your head, in the mind, you think of pore size, increase in pore size. But when you think about GFR, decrease in GFR, just think about progressive and permanent structural dysfunction of your nephrons, of your glomerulus and your tubules, your glomeruli and your tubulointerstitium. That's how you can differentiate proteinuria and decrease GFR. And do not get confused like why there is increase in pore size but there is decrease in GFR. Now let's quickly discuss about the major features of nephrotic syndrome. So there will be heavy proteinuria, that is more than 3 grams in 24 hours, and in dipstick you will see +3 or +4. So whenever in anywhere you see +3 or +4 dipstick, that is nephrotic proteinuria. The proteinuria is more than, the protein is more than 3 grams in 24 hours. That is heavy proteinuria, is seen in case of nephrotic syndrome. Along with that, you will see symptoms like hypertension, edema, hypercholesterolemia, hypoalbuminemia, because albumin is going to get lost so into the urine, so there will be decreased albumin, so hypoalbuminemia. And there will be microscopic hematuria, heavy proteinuria, microscopic hematuria. So, and what is nephrotic range proteinuria? That is only when large amount of proteinuria is present without clinical manifestation. That is your nephrotic range proteinuria. If you are going to say nephrotic proteinuria, there will be symptoms of nephrotic syndrome. But you say nephrotic range proteinuria, there will be proteinuria that is, similar to nephrotic syndrome, but there are no clinical symptoms as such, which are seen in case of nephrotic syndrome. So in nephrotic syndrome, you saw heavy proteinuria, that is more than 3 grams in 24 hours, that is in dipstick plus 3 or plus 4, and microscopic hematuria. In case of nephritic syndrome, you are going to see hematuria as the main feature. Hematuria will be the main feature, and there will be moderate proteinuria. Along with that, you will see hypertension, RBC cast, pyuria. But proteinuria is mild to moderate. So whenever you are differentiating nephrotic and nephritic, in both there will be proteinuria, in both there will be hematuria. But what is the predominant feature that we need to understand? In nephrotic, the predominant feature is heavy proteinuria. In nephritic, the predominant feature is hematuria. In nephrotic syndrome, there is hematuria, but that is microscopic. In nephritic, there is proteinuria, but that is mild to moderate. Along with that, we have some other features like hypertension, edema, and all these in like hypercholesterolemia and hypoalbuminemia is seen in case of nephrotic, whereas hypertension, RBC cast, and pyuria is seen in case of nephritic syndrome. Now, patient with basement membrane syndrome, where primarily the basement membrane is affected, that is your L port. In L port, there is genetically abnormal basement membrane. In case of good pasture, you have autoimmune response to JBM collagen 4. Just for the information, we will discuss these diseases in detail in the next video. But for now, let's have a rough idea about it. Now, both of these, the basement membrane is affected, but they are going to present some similar clinical features. That is your microscopic hematuria, mild to heavy proteinuria, hypertension, and increased serum creatinine. So this is about your Alport and Goodpasture syndrome. Now, there is some another syndromes where the vascular compartment is going to get affected, and this vascular injury is going to produce hematuria and moderate proteinuria. So that is your vasculitis, thrombotic microangiopathy, Apla syndrome, cholesterol emboli, hypertension, and sickle cell anemia. In these primarily involve your blood vessels, and because of that, they are going to present as hematuria and moderate proteinuria. So you should remember these also, because you must be able to differentiate these from the from the pathologies that are going to primarily involve inflammation. Primarily is going to cause inflammation, scarring, and all these features to the nephrons, to the glomerulus, and to the tubular interstitium. So this is how this unit you can remember, these are glomerular vascular syndromes, which primarily due to involving your vascular structures. Now there are some diagnostic tools that we will see quickly. Hematoxylin and eosin, it is going to visualize cellularity and the architecture. Pass stain, it is going to specifically for carbohydrate moiety that is present in the glomerular tuft and the tubules. And Jones methenamine silver, it is going to enhance basement membrane structure. Congorid for amyloid, mesenteric for collagen, and to assess the degree of sclerosis and the fibrosis, glomerular sclerosis and interstitial fibrosis. And direct immunofluorescence, see, these immunofluorescence whenever is discussed, it's about detecting antibodies, immune complexes, and all that. So detect IgA, IgG antibodies around glomerular basement membrane, IgA and IgG antibodies, and specific antibodies trapped against specific antibodies against trapped antigens and complements. So by immunofluorescence, you can visualize the specific antibodies and where they are actually located. or deposited, and also specific antibodies which are against some particular antigen or the complements. And the electron microscopy, this is for a specific location of immune complex deposition. So this was all about basic uh, pathology of basic pathology involving your nephrons. I hope you liked this discussion. I try to summarize and try to have a better understanding, so that whenever you encounter any disease that is involving nephrons, you can have a better visualization and you can come to a exact diagnosis. In the next video, we will be discussing all the diseases of nephron, that is, or nephritic, nephrotic, and all the syndromes. I hope you enjoyed this video, and if there was anything you liked or didn't like, please mention in the comment section, and let me know if you want any specific topic, for me to discuss. So this was it for today's discussion. Thank you so much for listening. Have a great day.